Hi, this is Dr. Fatthi Abdelbaki, Professor of ENT, Alexandria Faculty of Medicine, and in this video I'm going to present on surgical anatomy of the cochlea as it relates to CI. External surface anatomy for orientation. This is a left ear, this is the stapes, this is a round window, and this is the cochlear reform process, and this is the tensor tympani muscle in a cadaveric dissection. Actually, there is no external landmark for the cochlea, and for this reason, TOS AL in 2006 suggested to divide this part externally into three parts. One deep to the tensor tympani muscle, and which will be called the muscular portion of the cochlea. And then a small part above it, and in the deep part of it will be another part of the cochlea, and this part is called the geniculo-tegmental portion. But the main portion, of course, will be the promontorial portion. So we have the promontorial portion, the muscular portion, and the geniculo-tegmental portion of the cochlea. The anatomical part of the cochlea, as we all know that the cochlea is formed of the basal turn, and this basal turn encompasses inside it the middle and the apical turn. So we have a basal turn, then a middle turn, and then an apical turn. If we come to the basal turn itself, it is not one part only. It consists of four parts. The inferior part, then the ascending part of the basal turn, then the superior part of the basal turn, and then the descending part of the basal turn. So if we come from superior to inferior, the first section we are going to meet will not be the apical turn, but will be the superior part of the basal turn, or the upper part of the basal turn. And this is important to realize it when you follow radiologically. A correlation between the external surface and the internal structure. To start with, we start with the promontorial portion. And the promontorial portion is consisting mainly of the inferior basal turn, which is the bigger part of the basal turn. Besides this inferior basal part, there is a small part of the middle turn. The muscular part consists of the middle and apical turn, and on both sides there will be the ascending basal and the descending basal. So if you dissect deep to these portions, you are going to come across these parts of the cochlea, mainly the middle and apical, and parts of the ascending and descending part of the basal turn. And of course, geniculo-temporal part will be coming above or superficial to the upper part of the basal turn, or the superior part of the basal turn. So we have three portions: the promontorial portion, the muscular portion, and the geniculo-temporal portion. If we put this in mind, we can expect the locations of the different parts of the cochlea during our surgery. This, in my opinion, a very important illustrations, which is adopted from Stidham in 1999, and these illustrations show clearly the relation of the cochlear duct, and above it the scala vestibuli, and below it the scala tympani, to the round window area. And we have to keep this illustration always in the back of our mind whenever we are doing our cochleostomies. Again, this is the left ear with the round window and the stapes and the cochlear reform process. Here we expect to have the site of the cochlear duct, and above it will be the scala vestibuli, and below it is the scala tympani. As for cochlear implant insertion, we have the following destinations. Either we, and this is the main target, is to go to the basal turn, to the scala tympani of the basal turn. This is in most of the cases. But if this part is ossified and we don't have access to the basal turn, we have to move to the scala vestibuli of the basal turn, because sometimes the scala tympani is ossified while the scala vestibuli of the basal turn is patent. If both are ossified and we don't have access, so we have to resort to the middle turn. As for the approaches, we have two approaches for the scala tympani of the basal turn. One of them is through the round window membrane, and the other will be through the bony cochleostomy for the scala tympani of the basal turn. And we have one approach going to the scala vestibuli, and the last approach will be to the middle turn cochleostomy. Approach number one, the round window approach. And whenever this is feasible, and most of the surgeons prefer to go directly to the round window, because by doing so they are confident that they are inside the scala tympani, because the round window membrane is the portal to the scala tympani of the basal turn. The first structure to be seen in some cases, and not all cases, is this membrane, what we call the round window pseudomembrane or false membrane. It is not present in all cases. But whenever you find a membrane which is very superficial, this is not the true round window membrane. This is the round window pseudomembrane, and you have to remove it to expose the true membrane. As you notice here, it is very superficial across the edges of the round window, which is not the case for the true round window. After removing this false membrane, if present, we are going to identify the round window niche, and the round window niche will consist of the tegment superior and the posterior and anterior posterior pillars of the round window niche. So we have the tegment, we have the anterior and posterior pillar. Again, this is a left ear. And below we can notice a very hard bone which is called fustus, and we are going to describe it in more details soon. This is a round close-up view of round window membrane, and we can identify two portions, a vertical portion and a horizontal portion. And this picture is courtesy of Professor Jacques Magnon. After removing the round window membrane, we can identify inferiorly a bone crest which will be called the crista fenestra. This crista fenestra has different sizes and different shapes. Now this is a cadaveric dissection identifying the inside of the basal turn after removing the round window membrane. For orientation again, this is the left ear and this is the stapes, and here we have removed the round window membrane. We can identify the modulus around which the cochlea will wind around. This is the osseous spiral lamina coming from the modulus, and this is the spiral ligament, and in between the osseous spiral ligament and the spiral lamina should be the basilar membrane. Below, at the inferior surface of the scala tympani, will be the opening, the cochlear aqueduct. So this is the scala tympani below the osseous spiral lamina, basilar membrane and spiral ligament line, and above it will be the scala vestibuli. This is a cadaveric dissection with a crista fenestra, and if we don't drill this crista fenestra and we try to insert our electrode, and if this crista fenestra is prominent, it can deflect your electrode towards the osteospiral lamina and basilar membrane. So sometimes, and we have to resort to drilling of this crista fenestra, but in most of the cases now with the new electrode, with the new slim electrodes, we don't have to do such procedure for hearing preservation. The fustus is described beautifully by Marchioni et al. In 2014 with using the endoscopy, and they identified that these fustus have two types. Type A, which is in 70% of cases, and it stops at the round window edge. And this could be a very good guide to you to follow it to the round window membrane. Whereas in 30% of cases, they identify that the fustus come inside the scala tympani, extend to the floor of the scala tympani. Just at the same time, Wright and Roland in 2018 in the Atlas, they showed the crista semilunaris inside the scala tympani at the floor of the basal turn of the scala tympani. Whether this represents fustus B or not, we have to discuss it in details later. But now we have two crista, one at the edge of the round window, which is crista fenestra, and one inside the scala tympani, which will be called crista semilunaris, which is not present in all cases, and it's different of sizes, and usually we can overlook it. In the approach of round window, there are several precautions. Precaution 1, sometimes we are mistaken for a cavity as being a round window membrane going to the scala tympani. And in fact, this is not the case, and this is what we call the subcochlear canaliculus or the infracochlear tunnel. So usually be aware of that, and usually the round window membrane is closer to the stapes than expected. So if you are away from the foot plate of the stapes, usually think twice that this might be a subcochlear canaliculus, and it will lead to false insertion. The second precaution of the round window insertion, that sometimes there is an overhang, a bony overhang, over the round window membrane itself. And you have to remove this overhang. You can drill it safely, anteriorly and superiorly, but if we go posteriorly, again, to the illustration of Stidham, if you drill superiorly, you can be very close to the cochlear duct. It's what we call the hook region in this area, and it can damage the residual hearing. So usually be very cautious in drilling the posterior part of the round window. The third precaution is that sometimes the round window is missing. It could be missed because it is obliterated in cases of otosclerosis or other cases, or because it is rotated posteriorly and you cannot identify the round window. So what are your guides? Your guides, as we mentioned, inferiorly you follow the fustus and it can lead you to the round window membrane. Or you can have an idea about the approximate site of the round window in relation to the foot plate. In the middle part of the foot plate, it is around 1.5. So this finishes the first approach, which is the most commonly used approach, which is the round window approach. The second approach will be the cochleostomy, inside to go inside the scala tympani of the basal turn. Some surgeons prefer to do it even if the round window is identified. Sometimes it is used only when the round window cannot be identified. So in any case of these two conditions, you should know the surgical anatomy of the bony cochleostomy. So the types of bony cochleostomy, if you want to go to the scala tympani, you should be going antero-inferior to the round window. This is what is called antero-inferior cochleostomy. If you go antero-superior, you might damage the basilar membrane, the cochlear duct, and if you go more superior, you are going to go to the scala vestibuli. So keep inferior, antero-inferior. And the tendency now to go inferior more and more to be safe in the scala tympani. Sometimes we do extended or marginal round window, meaning that we remove the round window membrane and we can extend it anteriorly in a bony cochleostomy. This is the Jacobson nerve, and whenever you do the bony cochleostomy, you have to be posterior to this line, posterior to the Jacobson nerve, because in this area the bone is thin and the cochlea is superficial. If you go anteriorly, you will find that the bone is thick, and you have, of course, if you go far anteriorly, especially in case of ossifications, you might injure the carotid artery. If you don't see the round window and you don't have a landmark to do the cochleostomy, you keep the footplate of the oval window as a reference and drill your cochleostomy around 3 mm inferior to the anterior cusp of the footplate. So you be away of the cochlear duct and scala vestibula. The third approach, if for a reason or another the scala tympani of the basal turn is ossified, you have to go for the scala vestibuli of the basal turn. And here you have your landmark again, the footplate of the stapes, and it will be 1.25 away and 2.25 and to the anterior to the foot plate. This is the last approach, which is the approach to the middle turn. What are your landmark? Your landmark will be the cochlear form process and the footplate of stapes. Your cochleostomy will be 1 mm below the cochlear form process and 2 mm in front of the oval window. This is a summary of the 4 approaches. The round window membrane, which is the most commonly used nowadays, going through the scala tympani of the basal turn, then the cochleostomy, the bony cochleostomy in the scala tympani, then the scala vestibuli, then the middle turn. I'd like to thank you for your attention and hope to meet you in another presentation.